Professor Ali Aburahma will continue for the second talk, the effect of calcium burden on clinical outcome of TCAR.
Thanks again for the introduction. That's brand new. We just completed the analysis of this data just over 2-3 weeks ago, simply because there is so much debate about is calcium a major risk factors for making the stroke risk is much higher when you do carotid stenting. There are enough data to show yes. The question, is it similar in people who undergo transcarotid arterial stenting, or we call TCAR, which is relatively common now in the United States. I would say probably 1 out of 3 carotid intervention in America today is transcarotid revascularization, putting a stent through small carotid incision above the neck, which I'm sure all of you are familiar with. So the question is, calcium is a negative impacting factors in effect on a stroke, whether perioperatively or later on. So that's the purpose of this study here. Nothing to disclose. The CAR has been recommended or advised to be alternative to both the gold standard CEA and transfemoral stenting. However, the impact of carotid lesion calcification on both early and late outcome are not well defined. There are few studies showed association between calcified lesion with high risk of perioperative stroke following transfemoral stenting. Therefore, we felt let's look into transcarotid stenting, since we're going in a different geography and different location. So we conducted a retrospective analysis of prospectively collected data between June 2016 and December 2024. Patients were part of our patient enrolled in the clinical trial called Roadster 3 and 2, and in TCAR surveillance project, which is sponsored by the Vascular Quality Initiative of the Society of Vascular Surgery. So all data were actually registered and prospectively and followed. Initial patient for high risk for CA, but in the last 2 years, we start to apply TCAR for standard risk patient for CA. All patients have perioperative carotid duplex ultrasound in our accredited vascular laboratory. All had CTA of the head and neck prior to the procedure. All had immediate post-operative duplex ultrasound, and all procedure done by general anesthesia using the en route Silk Road protocol, which I don't want to go through it since most of you are familiar with. All selected according to the anatomical measurement to make it fit for what we call TCAR, and patients were classified whether symptomatic or asymptomatic, and technical procedure. Actually, we already described this in past publication over the last 2 years. How do you determine calcium determination? We were a little bit more sophisticated on this study, not similar what was done on the transfemoral carotid stenting, just looking to the burden of calcium based on what you see in the circumference. We looked into degree of circumferential calcification divided between 0 to less than 25% circumference, above 25 to less than 50, 50 to 75, or above 75. We also looked into calcification thickness, measured as the largest thickness of that calcium. We look also into the length of that calcium. So we look into 3 different parameters of calcium burden. A late follow-up consisted of immediate post-op and duplex ultrasound at 6 months and every 12 months thereafter. A follow-up also, patient integrated for symptom or no symptom, specifically TR stroke, and carotid instant restenosis was determined in validated data, which we published over several years ago, for defining above 50% and above 80% based on validated criteria. What are the results? There were 313 procedures. 301 of them were valid for analysis because they have at least 1 duplex ultrasound post-op, and patients were done, as you notice, between 16 and the year 24. Mean age was 71. 2/3 were male. 60% were asymptomatic. 39% were symptomatic. 30-day perioperative complications. Stroke rate, roughly 2%. Hematoma, 4%, but hematoma needed re-intervention was 1%. If you look at the bottom, stroke and death was 3%. What the effect of calcium on the 30-day perioperative stroke? Look into calcification circumference, below 50% versus above 50%. You could read this number as good as I. There was no significant difference between people with calcium below 50 versus above 50, roughly 1.7% versus 2.9%. Also, the mean calcium circumference, looking on the right side of this table, the mean of circumference for people who have stroke was almost similar to the mean circumference of people who have no perioperative stroke. Same thing was applicable for calcium length. Same thing was applicable for calcium thickness. There was no difference between thickness of above 2 millimeter thickness or below 2 millimeter thickness. Same thing with the mean of calcium thickness between people who have a stroke versus no stroke. When you combine both early and late stroke, looking also again calcium circumference and calcium length and calcium thickness, there was no significant difference between all stroke, both early and late stroke. Looking to restenosis above 50%, again, circumference, length, and thickness. There was no significant difference between above 50% restenosis between any other parameter of calcium burden. I'm going to skip some of these details. This is a tabulation of the 14 total stroke during a mean follow-up of roughly 3.5 years. And there was 14 of them to be noted. Only 4 of them were carotid related. The rest were non-carotid related. But looking to the extreme right of the table, whether circumference, length, or thickness, there was no prominent number to tell you apparently that was a dominant parameter for having a stroke in these 14 patients. Look into Kaplan-Meier curve for stroke at 1 year, 2 years, and 3 years. There was no significant difference between calcified above 50 versus below 50, 97 versus 95 at 3 years, 94 versus 95. That's freedom from stroke. Looking for calcification, 1 year, 2 years, and 3 years. Look at the bottom line, 93 versus 96. There was no significant p-value. Looking for stroke for thickness. Look at the bottom again. There's no significant difference. Looking for stroke and death. Look at 3 years, 72 versus 74. No significant difference. Regardless, length, calcium, circumference, or calcium thickness. Freedom from above 50% restenosis. 1 year, 2 years, 3 years. Somewhat similar. Look at 3 years, 87% versus 89%. Same thing for length, same thing for thickness. This analysis was not seen in any American or English literature except in one study by the group of San Diego, by El Sayed and Malas, published just 2 years ago. But to me, our probably data was a little bit more personal. Why? It was in major vascular center. This is vascular quality initiative, means all over the country, but the registry. But look into this data, just to take the slide and make it summary for you, there was no effect also of calcium in TCAR. However, there was significant impact of calcium in patients with transfemoral stenting, but not TCAR. Similar finding by our study over a few years ago, effect of calcium, look at line number 2, calcified lesion, stroke rate, 1.2% for non-calcified versus 6.3% for calcified. Similar finding by the Cetacea, the Italian group, and Catano. In summary, ladies and gentlemen, our present study showed no significant impact on effect of calcium burden in both early and late clinical outcome. Thank you very much for listening.